So this is the continuation of our program. This is the as planned. This is the free session. So we will be discussing a few stations, 6 stations. So today will be the third station. So today I'll be discussing about 2 stations, and tomorrow 2 stations. So today we'll be going for the pre-pregnancy counseling. So any station, it can be a structured discussion. I already told you. It can be simulated patient task, or it can be they can come for pre-pregnancy counseling, especially the maternal medicine. The maternal medicine can have, it can be a simulated patient task, it can be a structured discussion, it can be a pre-pregnancy counseling or pre-pregnancy care. So they come with a disease, like for example, diabetes or hypertension or sickle cell disease, anything. Before planning pregnancy, they would like to take advice because this disease can affect the baby and affect the pregnancy. So they want to take pregnancy counseling, that is which is very important also, because before the disease, unless the disease get controlled, it is not advisable to plan pregnancy. Some people are aware of it, and some people are not aware of it. So here, this first, we are going to the first case one. This is the case one, the slide which is shown down here on the bottom of this thing. So here, this is a simulated patient task. You're an ST5. Always you're an ST5. You're ST5 posted in a joint diabetic and antenatal clinic. So here, because it is a maternal medicine, it is a diabetes. So the medical disorders, mostly they'll be joint clinics. You are about to see Mrs. Julie Watson, 28-year-old with type 1 diabetes who came for pre-pregnancy care. She is on insulin since 18 years and her blood sugar control is very poor. Her HbA1c is 110 millimole per mole. Then this is her second pregnancy. In previous pregnancy, she had cesarean section in 34 weeks. And because for severe PE, preeclampsia. So that means it is a preterm cesarean section. So your task, they will give the task. So your task is you take the targeted history. That means once you see the case, you already know it is diabetes and uncontrolled. So targeted history related to diabetes you need to take. Explain her the result, that HbA1c which is very high, you have to explain, and you have to explain her the management option. So this way they give you in the RCOG, the case scenario will be like this. So they will give the simulated patient task or a structured discussion, whatever on the top, and they will give where it is, which clinic. This is very important. You have to note down the clinic and also what you are supposed to do. So when you so management plan, mainly it is control of the diabetes, then only she can plan pregnancy. Now, coming to the, we are starting with the case scenario. So now here, hello, introduction. Hello, I'm so-and-so, one of the doctors in the pre-pregnancy clinic. May I confirm your name and age, please? I'm Mrs. Julie Watson, doctor. How may I address you? You can call me Julia. So Julia, I can see from your notes, no agenda. I can see from your notes, or if the GP, suppose GP has referred, you can say GP, I can see from the GP letter, whatever it is there in the case scenario, you take that word. So I can see from your notes that you're diabetic on insulin, and as you're planning a pregnancy, you want to discuss about the pre-pregnancy care. And so you're here to discuss. Am I correct? Just make sure that it is the same. Whatever it is given in the case history, the scenario, you are telling the same thing. You are not adding extra things. So you just repeat the same and say, am I correct? Yes, doctor, I want to plan pregnancy because I'm diabetic and I want to plan pregnancy. So you say, that's what she answers. Then you say, appreciate always. Sometimes you have to appreciate the patient also. So I appreciate your efforts to come here before you get pregnant, and because you know, if you enter pregnancy with controlled diabetes, any condition should be controlled, not only diabetes. So if you enter the pregnancy with controlled diabetes, that is you're in a healthy condition, the chances of having a healthy pregnancy and a healthy baby are very high. So you should say, then the chance are very high. And because uncontrolled, if the sugars are uncontrolled, it can have, there can be some issues for the pregnancy, and also for the mother and for the baby also. So that's why you are telling, so you are conveying the message that it is important, that diabetes control is important. This is same thing for every medical condition. So I shall take your, no, let me take you, I shall take you through the pregnancy care plan and address all your concerns. Before that, I would like to ask you a few questions to know more about you, which helps us in making a safe management plan. So, can you tell her, will that be fine? Okay. Always involve the patient. Then, can you tell me more about more about you? Let me see your problem. Her diabetes. Huh? Then she will say, always that's an open question. She will say, doctor, I'm having this diabetes from so many years, and whatever complaint, suppose she has, she will say the complaint with her. So you say, suppose she says something, excessive thirst, excessive frequency of urination, or anything she can say, excessive vomiting, thirst, appetite, so frequent urinary infection, and itching, discharge, because candidiasis is very common. So such thing, anything she can say. Now, you say, suppose she doesn't say, you need to ask a few things about the diabetic symptoms of diabetes, because she is not pregnant. So, no point in asking pregnancy symptoms. So, you are asking her about diabetes symptoms. So, you say, do you have any excessive appetite? Do you feel more thirst? Do you feel frequently go to the pass urine, or urine she can understand, or do you have any infection in the urine, or waterworks you can say. Then few symptoms you can ask if she doesn't say anything. Then, now coming to the diabetes, you say about the diabetes, when was it diagnosed? So she is on insulin from 18 years, but you know that. But it must be before that. She must have tried some diet. So you need to know when it started. So can you tell me more about your diabetes? When it started? When was it diagnosed? And so I see that you are on insulin. You know that from the case scenario. I see that you are on insulin for 18 years. Are you taking regularly? These are the points you should ask. Are you taking regularly? And are you storing it correctly? Because there can be some, she may not take regularly, the sugar control will not be. Are you following the diet and exercise, which is advised? Diet and exercise, are you following your diet? Are you doing a regular, and listen to her answer. Are you doing a home glucose monitoring regularly? Home glucose monitoring? Because they can self monitor. Every day, 3-4 times she has to do the blood sugar test. So it will be difficult. So, and then are you doing a home blood glucose monitoring? And also monthly blood sugar testing? That's HbA1c. Are you doing? And how about your eye testing? How about your eye testing? Have you done your eye testing? Have you done your kidney testing? When was it? Suppose she says, yes, doctor. When was it? If it is less than 6 months, no need to do now. But if it is more than 6 months, you have to advise. Then, when was it done last? Okay. Now, when did you see your doctor last? That is very important. Whether she is seeing the doctor or not, we don't know, because her sugars are very uncontrolled. So she must have seen the doctor 1 year before. So take the history. So anytime, were you admitted anytime to the hospital? Either because of the increase in sugars, she can be admitted with increased sugars, and that is diabetic ketoacidosis, or she can be admitted with hypoglycemia. So you ask whether have you been admitted anytime to the hospital? Then that is over. And second thing, they have given that she is also having this hypertension. So she is on the drug called captopril. So you say, so that is why you have to see all the points in the case scenario. I also see that you have increased blood pressure, and so you're taking a medication called. I can see that you're taking the medication which is given, the captopril. So are you taking regularly? How is your blood pressure control? Is it controlled? So, since how long you have this increase in the blood pressure? When did you see your doctor last? Same. When did you see your doctor last? And now, let me tell you, so this medicine, this drug, captopril, is really good actually. But it is a wonderful drug. But in pregnancy, it is not a baby friendly drug. So you need to we need to change. We will refer you to the physician who will change the drug to a safer medicine to be taken during pregnancy. So now, can I see your notes? Because any medical condition, you see the notes. Any delivery, cesarean section, any surgery, you have to see the notes. I already told you. Now, this is over. Now, in the case scenario, they told us, they gave the information, and that this is second pregnancy. No, so if it is given, you ask. Otherwise, if it's not given, then you have to ask, is it your first pregnancy? Suppose it's not given. Then, so here it is given, it is second, this is a second pregnancy. So first pregnancy, she had eclampsia, so she had preterm cesarean section. So you need to ask, I see that you had you had your pregnancy before, and it was it was a cesarean section done before date, done early. That is because you developed a high increase in the blood pressure and protein loss in the urine. That's we say preeclampsia. So so how was the baby at that time? At the time of, because baby is preterm, no. How was the baby at that time? Ask about the baby's condition. And how is the baby now? Now how is the baby? And how old is the baby? And how was your recovery? How was your recovery? And how was your diabetes sugar control? That time also, because she's done diabetes since many years. So that time also she was diabetic. So how was your blood sugar control during that pregnancy? So then, can you see the notes? Cesarean notes you have to see always, because we want to know where the incision is given. We want to know whether in the upper segment or lower segment, because preterm, there is a possibility of giving incision in the upper segment. You need to know, that's classical. So, can I see your notes? Always take permission. And then coming to the gynec, that's over. Gynec history. 3, 4 things only. When was your last period? Because now she can be pregnant. That is why. When was your last period? Are your periods regular? How about your smear? Are you regular with your smear screening? Because see the age and ask. And if she's less than 25, don't ask. Then, are you using any contraceptives? Because she's planning pregnancy, she may be using, she may not be using. Now you have to ask. So, are you using any contraception? Okay. Now coming to the, do you have an idea about your blood group? Okay. The medical. Are you on now already she is diabetic, she is already hypertensive. Are you on any other medication? Sometimes they can be. And any other do you have any history of any clots? Sometimes they can be clot formation also. Then any allergies? Do you have any allergies? Allergy is very important. You should not miss. Then have you undergone any other surgery, any other operation other than the cesarean operation? Any other operation? Any family history. Family history of any increase in the blood pressure or increase in the sugar in the family, or any clot. These three are important because she is anyway diabetic, hypertensive. So family also can have. So then about the personal history, you take, do you smoke? And do you take alcohol? In that case, if she says yes, and you say, what's the quantity? If she says no, then doesn't matter. If she says yes, smoking, yes, doctor, I smoke, how many? She will say the number. You say, now, let me tell you at this point, let me tell you, smoking is can affect your health and pregnancy. So, if you permit, I'll connect you to the NHS smoking cessation program. So will that be fine? So for smoking, you have to take permission, refer them to the, then and there you finish off. Refer them to smoking cessation center. Drugs, if she's addicted to drugs, refer to the addiction, then alcohol also, de-addiction centers. If you permit, I would like to refer you to the de-addiction program. Then, if it is BMI, what can it, with the BMI is not given. Here it's not given. So you say, can you tell me your height weight ratio? Sometimes you can say BMI also. Height weight ratio, suppose it is more. Suppose it is more, then you say, I would like to, if you permit, I would like to refer you to the diet and exercise program, because increase in weight can cause some problems during pregnancy. It can, so it has got its own problems. So it can cause some effect on the pregnancy, like increase in the blood pressure, increase in the sugars. And so what do you do for living? Always ask her what does she do for living, and how will, because sometimes she may have to take leave also when she develops any complication. And how is the support? How is the support at home? And because of this condition and it is uncontrolled, she may be upset and depressed also. Are you down or depressed in the past few weeks? Is this condition causing you any disturbing you, or do you need any counseling? That's all. So this is about the information gathering. So now you finish off this information in 4 minutes. Then one after the other you ask. And then don't say, do you smoke, take alcohol and drugs? Don't say that. They get confused. So say one after the other. But be crisp and fast. Then would you like to add anything? Always end this with making sure she has no other doubts, no other information to give. Now, then information gathering, then examination. Examination, you just have to say, there's nothing to do an internal examination. because for everyone don't do abdominal examination, internal examination. You just say, I will ask, because she's hypertensive diabetic, you say, I will ask my nurse. If you permit, I'll ask my nurse to check your blood pressure and your blood sugar. Okay, now that is over. Now you are coming to the discussion. You're discussing with the patient that about her condition, uncontrolled diabetes and pre-pregnancy care. So, Julie, now let me explain to you about your pre-pregnancy care. Because she came for that, take that word. Now, I have seen your blood report. I confirm your name, age, and NHS number, patient safety point, and the value, the previous 3 months blood sugar value, that is HbA1c. You can show with the finger. The papers will be on the table in front of you. Show that report to her. This value is high. That is the previous 3 months report is high. So that means your sugar, your diabetes, that is sugars are not controlled. So we recommend, because she came for pre-pregnancy care, you tell her, we recommend for you to plan pregnancy when sugars are controlled, because it can uncontrolled. If it is uncontrolled, there can be some issues on the mother and also on the baby. So if sometimes she can say what problems it can cause, doctor. Otherwise, if she doesn't say, you say, can I explain about what can happen? Then you say, without that, don't continuously explain. Then you say, on the mother, the sugars can increase very high, can increase very much, and then they become unwell, and then then it becomes an emergency. That condition is called diabetic ketoacidosis, where they may have to be admitted. Don't say you. So generally you say, then they may have to get admitted. You may have to get admitted. Don't say that. Your baby, like that, don't say. Then second thing, the other thing is, it can fall also. The sugar can be very low. That also is not good. It also is a medical emergency. That time also they require admission and bring up the sugars. So that can happen. And also the kidney, this is because it's long standing. The sugar can have effect on the eye and also on the kidney, the function of the kidney. So you need to get them checked. So then during pregnancy, what happens, they can be increased blood pressure can increase, and sugar protein loss in the urine. That condition is called preeclampsia, and it can occur, especially she had this condition in the previous pregnancy. So they can be increase in the blood pressure and sugar protein loss, and also they can develop clots in the legs and lungs. So during labor, there can be increased. They may not set into labor by themselves. Then we may have to quick start the labor. Quick start the labor is IOL, induction of labor. Then there may be increased need for operations, operative delivery, that is cesarean operation. And also we may have to use cups and spoons, that is instrumental delivery, cups and spoons to help the delivery of the baby. After the delivery of the baby also, sometimes there can be increased bleeding. So these are the issues that can happen to the mother. Don't say this can happen to you. Don't say. So these are the issues that can happen to the mother. Then can I tell about what can happen to the baby? Always take permission. Then baby can have, with the uncontrolled sugar, they can have birth defects. The baby can have birth defects. They can be miscarriages. The growth of the baby can be affected. That is, baby can be small. It may not grow properly, or baby can become very big. Then that can cause some problem during delivery. That is, the shoulders can get stuck, and then sometimes there can be injuries to the baby also during delivery because of the big size of the baby. So these are the problems, and also during delivery, the baby's heartbeat can stop during delivery. That is called stillbirth. Or after delivery also, the babies may not survive. That's neonatal death, you say. And they may need, because they can have some breathing problem, they may need to get admitted to the intensive care unit. That is NICU, intensive care unit. So this is what can happen in an uncontrolled diabetes. But let me tell you, if it is controlled, these issues can be reduced. Always assure her, can be reduced. So shall I tell you shall I tell you what care you need to take to control the blood sugar? Shall I tell you? Okay. Then she says, yes, doctor. Then she'll say, or she herself say, what to do, doctor, then how to control my sugar. So then you say, now, as she came for pre-pregnancy counseling, then you start with the pre-pregnancy care. See, say, so now to control this, reduce these complications, your diabetes need to be controlled. So there will be some lifestyle modification. Take this word. This word is very important. Lifestyle modification. That means you need to we will see a dietitian and you need to follow diet and exercise program. So, and you maintain the optimal weight. That will be ideally 27, less than 27. So, diet exercise program, we will tell you, you need to attend the diet exercise program. So, we will be referring you to the dietitian, and regular, you need to do the regular, you need to take the insulin regularly. You need to do, see your diabetes specialist, and according to his advice, take the insulin regularly. Do, that is, next is insulin. So, diet exercise, first thing. Second thing, see your doctor, diabetic doctor, and because it is uncontrolled. So, and he will adjust the dose, and you do the regular home glucose monitoring. And second thing is the previous 3 months blood sugar also you need to see. So, this is about the so diabetes, you have to involve the specialist here because it is uncontrolled. So, then third thing, you need to get blood testing is over. Diabetes specialist is over. He will adjust the dose. The third thing is you need to get your kidney and eye testing done if it is not done in the previous 6 months. Then because now it is uncontrolled, you need to take the precaution, that is contraceptive advice. You need to avoid pregnancy now. Avoid pregnancy till the sugar control. So then, once the sugars are controlled, then you can inform your GP, because the GP is the first contact. Inform the GP, and then so you inform the GP, and then once the sugars are controlled, then you start the planning pregnancy. Then you start the folic acid. Then what is you need to maintain sugar. She should know what is the normal sugar. What is the normal sugar she has to maintain? You tell her. You aim for fasting blood sugar to be between 5 to 7 as she wakes up morning. Fasting blood sugar 5 to 7 millimoles per liter on waking up, and other times before meals, pre-meal 4 to 7, 5 to 7 morning, and 4 to 7 other time of the day before meals. So this is what you have to tell her, because she doesn't know what is the normal. She must have been told by the diabetes specialist, but she must have forgotten. So this is about the day-to-day blood sugar, and the 3 months value should be, ideally, it should be less than 48. 48, we aim for 48, that means otherwise 6.5%, less than 6.5%. So this is what we need to aim for. So suppose now it is uncontrolled sugar, if it is more than 86 or 10%, we will advise not to plan pregnancy. Not to plan pregnancy at all. So naturally, she should not plan. It's very high. Now, once your sugars are controlled, once your blood sugars are controlled, then you can plan pregnancy. So your GP will tell you to plan pregnancy. Then once you plan, till that time continue the contraception. Once you plan pregnancy, start the folic acid. Then once the pregnancy test becomes positive, and then your GP will be referring you to the antenatal clinic. So let me tell you, this is a high-risk pregnancy. Diabetes is a high-risk pregnancy. Now you're telling about the antenatal care. So once you become pregnant, the high-risk pregnancy, you will be under consultant-led care with a team of doctors looking after you. That is in a it is a joint clinic. Our obstetrician, the diabetes doctor, and then the scan doctor, because there will be frequent scans, and the so senior midwife. So few names you take. Then you need there will be frequent visits and frequent scans to check frequent jacks, and the diabetes doctor will monitor your blood sugars, and he will adjust the dose accordingly. So then you already during pregnancy, you need to do self-monitoring, and also HbA, the 3 months value of the blood sugar, that's HbA1c, you need to do at booking, that is first trimester, second and third trimester. Now, because now you are also having blood pressure, your physician you'll be seen by the physician also, and he will change that medicine to the safer medicine. Then you will be meeting the diet, continue the diet exercise program, and then so your target during pregnancy. What this is pregnancy now, so you need to tell her the target blood sugar. Before you told her about the pre-pregnancy. Now pregnancy, the target levels what she should maintain. Fasting 5.3 millimole per liter. 1 hour 1 hour is 7.8. 2 hour is 6.4. 5.3, 7.8, 6.4. Here no OGTT. Here it's only blood sugar because she is already diabetic. So then folic acid you have already started. 5 milligram you should specifically say take it for 3 months after conception, after pregnancy. Take it for 3 months and stop it. High dose 5 milligram. Then once the scan is over from 12 weeks, then we will put you on aspirin, drug called aspirin blood thinner, because previous pregnancy you had increase in the blood pressure and protein in the urine. So that is preeclampsia. So then about the scans, one scans will be done at 12 weeks, 20 weeks, and that is to know whether baby has any genetic abnormalities at 12 weeks, and 20 weeks to know any other any defects, birth defects, and from 28 weeks we'll see the growth of the baby, growth and well-being. And at the same time we will be doing a scan of the heart also, baby's heart, that is at the 20 weeks. Now mode of delivery will be discussed with you at 36 weeks, and then we aim for vaginal birth, and cesarean section will be done only if the weight of the baby is more than 4.5. So that's all. Then sugars will be continuously monitored during pregnancy and during labor also. During labor also sugars will be monitored, and your diabetes doctor will be monitoring you. Then after delivery, breastfeeding is encouraged, and early breastfeeding, and also the sugar, your diabetes doctor will be adjusting the dose of the insulin, and the blood sugar monitoring also will be done. So this way we will take care of your pregnancy once you become pregnant. Any other doubt? Do you have anything else? Am I clear? Am I clear so far? Do you have anything else to ask me? Okay, now that is over. I will document whatever we have discussed. This is the information leaflet that is about the diabetes, and also I will connect you to the support group. So document, information leaflet, support group. Then till your sugars are controlled, you will be following the contraception, and you can use any type of contraception, and then we'll refer you to the diabetes doctor for your sugar control, and physician also, because he will change the medication. So that's all. So thank you for your time. So this way, take it through. The main thing is to tell about the pre-pregnancy, few words about the pre-pregnancy counseling, and once she become pregnant, briefly about the antenatal. So, and pain relief, this and that, monitoring and all, no need to say. Just briefly, and frequent visits, frequent scans, diabetes, especially diabetes, and sugar control, insulin. And during labor, she can have vaginal birth. Plan of the birth will be discussed with her, and vaginal birth she can have unless the baby is more than 4.5. And it will be a planned delivery, that is between 37 and 38 plus 6, because she is diabetic on insulin. It will be planned delivery. So this way you have to take the station of the diabetes. So now we have done with the first case, that is diabetes. We'll move on to the second case, that is postpartum. Now it is maternal medicine, so it can come as a diabetes also, pregnancy with diabetes. So then whatever complications I told you, you will have the same thing in the pregnancy also. That is pregnancy, same thing. What is the difference in pregnancy, diabetes at 28 weeks or 32 weeks, whatever, during pregnancy? Type 1 diabetes, same thing. You will tell her the control of the sugars. Then you will say the effect on the mother, effect on the baby. Then you will say antenatal care, intrapartum care, postpartum care, and then closure. Only thing is pre-pregnancy counseling you will not say here. And in pre-pregnancy counseling, because she just briefly you have to say the antenatal care. So that is the first case is over. Now we'll move on to the second case. That is some postpartum problems will be there. They can ask one problem from the postpartum complications also can be there. So anything they can ask. Postpartum, commonly they will ask postpartum headache, then mastitis, postpartum, then perineal tears. Then they can ask about the pulmonary embolism. So today we are discussing about the pulmonary embolism. So postpartum. So here that is the case number 2. This also is a patient stimulated task. So your because I'm explaining and taking you through the station, it is taking more time. So once you listen, whatever explanation, if you remove, you can manage in 10 minutes. So you are ST5 on call today because pulmonary embolism is an emergency. They come as it is actually, she is, the case scenario says you are about to see Lily Jacob. You are about to see Lily Jacob, Mrs. Lily Jacob, 28 years. She had cesarean section 2 days back. So she is in the hospital only. Remember that. And it was her, this is her first pregnancy. So that means no pregnancies before. She complains of chest pain, shortness of breath, and a junior who must be on the duty, she saw her and started her on heparin last night. And then after which she became better. So there was a history of prolonged leaking. Her baby is in ICU, BMI 36, and investigations are enclosed, chest X-ray normal, ECG, sinus tachycardia. So you have to take relevant history. These things you have to see and answer her concerns, make a management plan. So this is what you have to concentrate. What things they asked, only you ask, tell, and don't say extra things. So now, so how to start this case? So here you got the points. BMI is high. Prolonged leaking can lead to infection. So she can develop sepsis. This is one. Baby ICU, must have had breathing problem. We should know. BMI 36. So cesarean section. So these are the things which you got. Shortness of breath, chest pain. Okay. Now from this only you will know that it's an embolism. Now here, hello, you have got the two investigations. Hello, I'm so and so on call today. I'm on call today and I have been called to see you. Because you're having chest pain in the chest and shortness of breath. So, am I talking to? Don't say, may I know, confirm your name and age, please. Because she's admitted. So, she's admitted, her case file is there. Am I talking to? Just confirm her name. Am I talking to Lily Jacob, 28 years? Am I talking to? Yes. Yes, doctor, I'm Lily Jacob. So, how may I address you? She can say, Lily. I'm sorry to see you in such a difficult situation because she is having breathlessness. So, she is not comfortable. Say, I'm sorry to see you in such a difficult situation. Let me give you some oxygen because you know she's shortness of breath. Let me give you some oxygen. And if she's not in propped up, you can say, I'll make you propped up position. Let me give some oxygen. We need to, we need to upgrade your care because urgently, because she must be in the ward, postnatal ward. She must have been shifted. So we need to upgrade you to the high dependency unit or intensive care immediately. So because it is a pulmonary embolism, so you tell her we need to upgrade your care. We need to shift you urgently to the ICU immediately. We are worried. We are worried because see Lily, we are worried because of your complaints. Because you are complaining of chest pain and shortness of breath. So we are worried. There could be some possible, why, because why doctor, why I am having this problem. Then you can say there can be some two possibilities. One could be there can be a clot. A clot must have been there blocking one of the blood vessel of the lung. This condition is called pulmonary embolism. The other possibility can be some problem in the heart. So I'm not sure at the moment. At the moment, I'm not sure. We need to do arrange some urgent scan. We need to arrange a scan, urgent scan, special scan that is called a ventilation perfusion scan. So for you, that is, so that will tell us the diagnosis. That will confirm whether the clot is there or not. And then, so we can start the treatment immediately or continue the heparin immediately. Continue the heparin. So then, will that be okay for you? That means you're going to shift her. That's why you're asking. Without asking her permission, she may not. So we have to take permission to shift her also. So will that be okay for you? And because anyway, she already is getting some heparin. She already got some heparin. Now we already gave her some oxygen because you asked her, shall I give some oxygen then? How are you feeling now? Are you comfortable now? Now, can you tell me more about you? Exactly what happened? Can you tell me more about you? Then she will say, doctor, I developed chest pain. Suddenly I developed chest pain and breathing problem. These are the things she will say. If then otherwise, what you have to say, if she doesn't say properly, you say, when did you develop this pain in the chest? When did you develop, can you, Lily, when did you develop? Then she will say, whatever time, night, 8 o'clock or 7 o'clock, sometime she will say. And where is the pain exactly? Then one or two things. And how severe? And are you comfortable now? Because she already, you asked, if you have already asked, don't ask again. Then what about the short breathing problem? Are you comfortable now? Are you able to, I mean, are you comfortable, or you need, you're having difficulty in breathing, still you're having, so okay. Now, are you having any other problem like cough, coughing out blood? Coughing out blood, do you have, because pulmonary edema can be there. So, do you feel any, is there any pain in the leg, in your leg? Because we want to rule out DVT, deep vein thrombosis. Is there any pain in the leg or swelling in the leg? Any fever? Do you have any fever? Any problem in moving around? And because of the any pain in the swelling in the leg, are you wearing any stockings? So, because she is had cesarean, usually we give stockings. Now, these are the information things you have to ask. History of present illness. Then, I have seen that you have been given injection under the skin. Do you have any idea what it is? She said, no, doctor. So, it is a blood thinner called heparin. So, have you been given any time during pregnancy? This injection, have you been given during pregnancy or immediately after delivery? You want to know whether she had any history of any DVT in pregnancy. So, now I could see from your notes that you had, now this is over, present illness is over. Now, you're going for the cesarean present pregnancy details, delivery details. I could see from your notes that you had cesarean section 2 days before. Why was it done? Can you tell me why the cesarean operation was done? And so then she says some reason she will say that there's no progress in labor because she had prolonged, there's no progress in labor and all she can say. So then you say, then okay, details you take, and can I see the notes? Always say that's in notes. And then you say, how about just a few symptoms about postpartum symptoms. One is, how about the bleeding? Is it normal bleeding? That is lochia. Normal. Do you have any pain in the tummy or pain in the breast? Because she's baby is in NICU. So pain in the breast, pain in the tummy. Then how about the excessive bleeding? You already asked. Then bowel, any problem with the bowel? Because when bowel opened or not, we want to know. And bladder symptoms. So any issues with the waterworks? Any issue with the bowel opening? That's all. So are you taking enough of fluids? Fluids, if she takes, doesn't, if there is no hydration, proper hydration, it can lead to clot formation. Are you taking enough of fluids? And are you mobilized? Mobilized is very important. So because she's anyway 2 days before. So mobilization is important. So these are the things which you should ask related to the delivery. Then I see that your baby is admitted in the NICU. Have you seen your baby? Did they tell you why baby is admitted? Did they tell you? And then have you seen your baby? Are you feeding the baby? Like, are you breastfeeding or collecting the milk and giving? Just 3 things. So then I will inquire about the baby from the baby doctor, and I'll inform you about the baby. So now now that is over. Obstetric history is over. Any you know that so this second thing is medical history. So previous obstetric history, no need, because it's the first pregnancy. So medical history, because shortness of breath. Do you have any problem in the heart? Anytime is there any problem in the heart? Then you want to rule out heart cardiac problem. Any time you have asked clots during pregnancy, because then you can non-pregnancy also she can have clots. So anytime you had any other medical condition like clots, any allergies. So then family history, no need of asking blood group here. It's irrelevant anyway. Blood group is already known to her. The delivery, everything is over. Don't ask any blood group. Family history, any family history of her name specifically hard you ask. Don't ask family history of concern. Just specifically you ask heart disease, any heart disease or any clots in the family. She may say whatever she is given instruction, she will say. Then coming to the personal history, do you smoke? Smoking is important. Smoke or and then you say, how is the support? How is the support at home? Because then she needs support. And that's all. Then would you like to add anything? Because sometimes she may forget to say give some information, or you may forget to ask. Now examination. So after that you say, if you allow me, I would like to tell my nurse to check your blood pressure. Nurse will do these things. You don't say I will do. You say I will tell my nurse to check your blood pressure and oxygen saturation. Then I will examine your tummy, and also your heart and lungs, and also your legs, any swelling in the legs. I will examine your legs and examine your tummy for the wound. Because she had cesarean section, I would like to check the wound. So now that is over. Now you are coming to the discussion. That is, now this is the applied clinical knowledge. So now Lily, let me explain to you. Because she's pulmonary embolism, sometimes you can ask, do you want anyone to be with you for support? You can ask, because it is a pulmonary embolism, it's an emergency. And so you can ask, it's not BBN actually, but for support. Would you like to call someone to be with you? Okay, no doctor, whatever. So now let me explain to you your condition. From your history, that history and examination, and we are suspecting we are suspecting the possibility of a clot forming in the lungs, in the blood vessel of the lung, because you're having these symptoms already, shortness of breath, no, that's and chest pain. So we are suspecting a clot formation in the vessel of the lung. And but we need to confirm it. So we will arrange a special scan called ventilation perfusion scan, otherwise called VQ, ventilation perfusion scan, where here what you have to breathe in gases. Just you have to, 1 or 2 words you say, breathe in gases, and then we will give some injection. That's contrast. We'll give some injection into the vein. So this will show exactly, if the clot is there, it will show the clot. So this we will do this, which will to confirm that there is a clot. At the same time, I would like to tell you, you may have to stop breastfeeding the baby for 12 to 24 hours after this test. That then other thing what we would like to do is, we would like to send some blood test. For some blood test we would like to send. The other thing that is like, no need to say kidney, if there is time you say, but no need. Some this clotting, we like to send some blood test, and that is to check the blood strength, to check the clotting protein, and also check the liver and kidney test. Then second thing is, we have 2 reports with us. Only 2 tests are done for you. That is chest X-ray and ECG. I have confirmed your name, age, and NHS number on both. Your chest X-ray is normal. ECG showing some increase in the heartbeat. But anyway, we will do the scan and decide. So then after that, then I will speak to my now you have to involve the multidisciplinary team. Now your care will be it will be under a team of doctors. This is a multidisciplinary team. So your care will be under a team of doctors. That will be our physician, and also our blood doctor. Then also, because because she also has fever, because prolonged leaking, sometimes they give fever. So because of that, suppose it is given in this case scenario, then you say, or in the observation findings, if the temperature is more, in that case you say, and the microbiologist. Then the microbiologist, then we will, if there is fever, we will, suppose fever is given, you say, because you have fever, we'll start the antibiotics and the sepsis 6 protocol. So your care will be under team of doctors. That is our obstetrician. Then also the blood means the blood doctor, and then also the microbiologist. Then counselor, microbiologist. So then once we need to monitor you continuously. That is in HDU. Now once a clot is confirmed, we will continue this blood thinner. That is the injection which is given under the skin. We will continue. This injection will prevent further formation of the clot, and also it will not allow the clot to become bigger. So these blood thinners are given and then usually the clot will resolve in 5 days, 5 to 7 days. Then, but after that, we will switch over to oral tablet because it's an injection. We will switch over to the tablet, and that tablets are given for that. Is also blood thinner. It is that's called warfarin. It is given for 3 months, and both are safe in breast. You can feed, both are safe for the baby. You can feed the baby, do the breastfeeding. So now, then after when we start these blood thinners, we will check your blood regularly, check that for the clotting protein. And then once the treatment is complete, then that means after 3 months, we will see you in the joint clinic to see whether the clot is still present or not. So, am I clear so far? Am I clear? Okay. Then there can be some implications also. Sometimes role players say, doctor, in future, what will happen to me? Or your advice, you have to say. Like, can I tell you about the implications of this condition? So, yes, what then you should say in the next pregnancy, this problem can occur again. So that is the recurrence. That's called recurrence. Though this pregnancy, next pregnancy, there can be clot formation again, and otherwise, anytime you undergo any operation in future, this clot can form. There can be clot formation. So then that is so, and then when it forms, suppose you will be treated accordingly. Now, coming to the contraception, we will, if suppose you want to space the birth spacing methods, we will refer you to the contraception clinic, and they will give you the contraception avoiding estrogen, a hormone called estrogen containing pills, because they are not given if any woman has a clot. So then we will keep you under follow-up. So as this, that is about the case is done. Now, the last thing, clinical governance. As this complication has happened, we will raise an instant report. Instant report, never forget. And you should know when you should raise the instant report. Few conditions you should know. So, as this complication has happened, we will look into the matter. We will raise an instant report to know why it has happened and what can be done, what could have been done to prevent it. So, and then once the report is ready, we will discuss, our consultant usually discusses. Our consultant will discuss with you. Now, so then, if you will discuss with you. If you have any, do you have any other concern? Now, I will inform my consultant. He will be coming and seeing you. My consultant and blood doctor, they'll come and see you. Or you already say, I have informed my consultant. They'll come and see you, blood consultant and blood doctor. Then we will make arrangements. To shift you to the high dependency unit. And then I'll make arrangements. Meanwhile, if you have any concern, you can inform the midwife. You can inform the nurse. She will call me. So thank you for your time. So here, no need of giving patient information. She's already admitted. No need of giving information leaflets, support group. That's not correct here because she's admitted. She's an emergency. So you're going to shift her to the HDU and you're going to inform the consultant, the concerned persons. And then you want to involve the radiologist also because you're sending for imaging. So radiologists who are all required, you have to involve them. Hematologist because heparin. So hematologist, radiologist, consultant are involved in this plus nurse. So this way you will manage this case. So, the discussion is over now about the 2 cases. Okay. So tomorrow we will move on to the other 2 cases. That will be one gynec case and one subfertility case. So tomorrow we will discuss. And so I want to tell you on Sunday, day after tomorrow I'll finish off by 2 more cases, and total will be 6 cases. Yesterday's 2, today 2, and tomorrow I'll be discussing 2. And all the 6 cases you can present to Dr. Padma. So who are all interested to present your case in 10 minutes. So she will see how you are presenting. Dr. Padma is our mentor. So she will assess you. You need to present to her in 10 minutes, and whatever you have listened to and whatever you want. You need not present the same way, but whatever you feel, you can present to her the same topics, the same 6 topics. Today's, yesterday's and tomorrow's. present to her, and whoever want to present, give your names in the group, in the Telegram group. So Dr. Padma, day after tomorrow, she will take the feed, your case. She will listen to your case presentations between 7 to 9 on Sunday. Okay. So okay then, Dr. Subbalakshmi, you are here. Sugirta, you are there. I can't make out the name of the doctor. So this is over. The session is over today. Padma, Dr. Padma. Hello, Dr. Padma. So shall we close this? Close the session? It's
Yes,
over. Yeah, it's over. Don't waste your time. I just want to tell you, practice as much as possible. Don't waste your time, because this 3 months prepare very thoroughly. The basic things you practice, and see all the patient information leaflets. So practice as much as possible. Padma, it's done today.
Yes, ma'am. Yes, ma'am.
Okay then. I told them they can give the names in the group and they can present to you on Sunday between 7 to 9.
Yes, ma'am. I'll put a
Will be
message too.
sent.
I'll put a message too.
Yes. And the link will be
Thank you,
sent.
ma'am. Thank you.
Okay. So bye. Good night, all of you.